Hello everyone. Today we'll discuss about mechanism of breathing, also known as mechanism of pulmonary ventilation. Pulmonary ventilation includes mainly two processes. Number one, that is inspiration, which refers to inflow of atmospheric air into the lung, and this occurs when intrapulmonary pressure falls below the atmospheric pressure. Here you can see when intrapulmonary pressure decreases less than atmospheric pressure, that is inspiration. And expiration refers to outflow of air that occurs when intrapulmonary pressure rises above the atmospheric pressure. Why is it so? Because we cannot change atmospheric pressure, we can change only intrapulmonary pressure. Now, changes in the intrapulmonary pressure, which governs the respiratory cycle of inspiration and expiration. They are related to changes in the intrapleural pressure. This is intrapleural pressure, pressure between parietal and visceral pleura. Changes in the intrapleural pressure, they are brought about by changes in the size of thoracic cavity. Expansion of thoracic cage leads to fall in the intrapleural pressure, and decrease in the size of thoracic cavity leads to increase in the intrapleural pressure, because pressure and volume multiplication, that is constant. So when chest wall expands, volume increases, pressure decreases. And change in the size of thoracic cavity, that is brought about by various muscles of respiration. There are muscles for normal respiration as well as muscles for forceful respiration, known as accessory muscles for respiration. Now, let us discuss here. These are different muscles I have shown. We'll discuss in detail muscles of normal, or you can say tidal inspiration. They are diaphragm and external intercostal muscle. Normal expiration, that is a passive process, and it does not require active contraction of any muscle. So muscles for expiration, they are always muscles for forceful expiration, and they are our internal intercostal muscles. You can see here, these are internal intercostal muscles, as well as abdominal muscles. These muscles are rectus abdominis here, transverse abdominis, internal oblique muscle, and also internal intercostal muscle. Then accessory muscles for inspiration. These are scalene muscles. Here are scalene, sternocleidomastoid muscle, and serratus anterior muscle. Now we discuss about mechanism of tidal respiration. Inspiration is an active process because normally it is produced by contraction of inspiratory muscle, which produces negative pressure. So it is known as negative pressure breathing. Whereas when we use respirator to inflate our lungs, that produces positive pressure. So it is known as positive pressure breathing. During quiet inspiration, quiet breathing, we require contraction of diaphragm and external intercostal muscle. Because of contraction of diaphragm and external intercostal muscle, all the three diameters of thoracic cavity increases. They are vertical, transverse, and anteroposterior. We will discuss in detail. Now, what is the role of diaphragm? Diaphragm is a dome-shaped musculotendinous partition between thorax and abdomen with convexity directed towards thorax. Muscles of diaphragm, they arise from xiphisternum, inner surface of the lower 6 ribs, as well as lumbar vertebrae. Nerve supply, innervation, that is motor nerve supply to the diaphragm is by phrenic nerve. Root values are C3, C4, and C5. In the tidal inspiration, quiet breathing, 70 to 75% of expansion of the chest, that is caused due to contraction of diaphragm. When diaphragm contracts, following changes occur. Number one, that is the dome of the diaphragm gets flattened and the level of the diaphragm is lowered, and therefore vertical diameter, this diameter. This is the relaxed state of diaphragm, this is contracted. So the vertical diameter of the thoracic cavity increases. During quiet breathing, diaphragmatic movement is only 1.5 cm, and during forceful respiration it is as much as 7 to 10 cm. Second effect of descent of diaphragm. First, that is flattening increases vertical diameter. Second, descent of diaphragm causes rise in the intra-abdominal pressure here, which is accommodated by reciprocal relaxation of abdominal musculature. Then third effect, that is because of contraction of diaphragm, lower ribs, they are lifted, and because of that there is expansion of thoracic cage. This expansion takes place in the lateral or transverse dimensions as well as antero-posterior dimensions, which are known as pump handle as well as bucket handle movements. We will discuss in detail. So again you can see this is the diaphragmatic movement. Another is position of diaphragm and its postural relationship. Sitting is the most comfortable posture because diaphragm is not down due to gravity and it is not pressing over the abdominal contents. Standing position, abdominal muscles they contract to cause increase in the intra-abdominal pressure to increase and ascent of diaphragm. And lying down position is the most uncomfortable position. So again you can see this is the movement of diaphragm. Another thing, during the action of diaphragm, the abdominal muscles, abdominal organs and abdominal muscles, they support the diaphragmatic dome and acts as fulcrum, while the diaphragmatic contractions raises lower ribs. So this is all about the role of diaphragm. Second is role of external intercostal muscle. The fibers of external, you can see here, these are the fibers of external intercostal muscle. They slope downward and forward, like we are placing our hands in the pocket, like this, downward forward. They are attached close to the vertebral ends of the upper rib, here, vertebral ends of the upper rib, then lower ribs. They form pivot-like joint. With the vertebrae, the ribs slope obliquely and downward and forward. When the external intercostal muscles contract, because of the lever effect, the ribs are elevated. So you can see elevation because ribs are downward forward, and because of contraction of external intercostal muscle, there is elevation of ribs. So there is increase in the transverse diameter as well as increase in the antero-posterior diameter. That is by bucket handle and pump handle movement. Bucket handle movement increases transverse diameter and pump handle movement increases antero-posterior diameter. Again you can see these are the external intercostal muscle. Now this is bucket handle movement. Role of diaphragm is also there for the bucket handle movement and pump handle movement, and also there is a role of external intercostal movement muscles. Now we discuss what is pump handle movement. Second to sixth rib, they slope downwards and forward. On inspiration, they move upward and assume more horizontal position. Because of this movement, there is increase in the antero-posterior diameter. Here you can see like the movement of handle of pump, there is movement of rib, and that results in increase in the antero-posterior diameter. Bucket handle movement, 7th to 10th rib, they swing outward and upward in inspiration, and because of this movement there is increase in the transverse diameter. You can see here this is the movement outward and upward, and because of this movement transverse diameter increases. Another is role of laryngeal muscles. Abductor muscles of larynx, they contract during inspiration and they increase pulling of the vocal folds or vocal cords apart and opens the glottis. This is laryngeal muscles. They are also supplied by recurrent laryngeal nerve, which is a branch of vagus nerve, and that paralysis leads to inspiratory stridor, that is inspiration with loud sound. Applied aspect. Normal ventilation at rest, that is maintained either by diaphragm or external intercostal muscle. In bilateral phrenic nerve palsy, adequate ventilation, that is present at rest, it can be maintained by external intercostal muscle alone, but respiration is somewhat affected. Spinal cord transection, when the spinal cord is transected either above the third segment, because root value for phrenic nerve they are C3, C4, C5. So whenever the transection is made above the C3 level, what happens? The person cannot survive if he or she is not supported with artificial respiration. And whereas the transaction is made if it is made below fifth segment, C5, if we are transacting, then the respiration remains normal. Okay. So this is all about the tidal inspiration. Next is tidal expiration. As we have discussed, expiration is a passive process in quiet breathing, and it is brought about by elastic recoil of the lung tissue and decrease in the size of thoracic cavity. That is because of relaxation of muscles of inspiration. They are diaphragm and external intercostal muscle. Also, there is increase in the tone of the muscles of anterior abdominal wall, which forces the relaxing diaphragm upward. Serratus posterior inferior muscle also play a minor role in pulling the ribs downward. So this is all about the tidal respiration. Okay. Now we discuss about the forceful respiration. Forceful respiration, that is also having two parts, forceful inspiration and forceful expiration. Forceful inspiration is characterized by forceful contraction of diaphragm. Diaphragmatic contraction, that is the movement during diaphragmatic contraction, that is 7 to 10 centimeter during forceful inspiration as compared to 1 to 1.5 centimeter during quiet breathing, quiet inspiration. Second is forceful contraction of external intercostal muscle. They cause more elevation of ribs and leading to more increase in the transverse and anteroposterior diameter of the thoracic cage. So again you can see this is a diaphragmatic movement and movement of the external intercostal muscle. Other is accessory muscles. They also contract during forceful inspiration. Which are they? Number one is sternocleidomastoid muscle. Here, contract and it lifts the sternum upward. And because of lifting of sternum upward, there is increase in the anteroposterior diameter. Scalene muscles, they contract and they lift first two ribs upward. And serratus anterior muscle contracts and it also lifts ribs upward. Now, forced expiration. Forceful expiration is required when the respiration is increased during exercise, as well as in presence of severe respiratory diseases. So, during forceful breathing, the elastic forces are not powerful enough to cause the necessary rapid expiration. So, we require extra force, and this extra force is achieved by contraction of abdominal muscles. They push the abdominal contents upward and compressing the lungs. So now expiration also becomes active process. So first and foremost, that is contraction of abdominal muscles. Abdominal muscles we have already enumerated. They are abdominal recti, transverse abdominis, and internal oblique and external oblique muscle. Now compression of abdominal contents, which increases the intra-abdominal pressure. Because of compression here, intra-abdominal pressure increases and forces the diaphragm upward. So there is decrease in the vertical diameter. That is first effect. Second effect is downward pull on the lower ribs. Lower ribs, they are pulled downward. So there is decrease in the anteroposterior diameter. Third effect of contraction of abdominal muscle is fixation of lower ribs. Lower ribs are fixed so that internal intercostal muscle can act more efficiently. So which are the effects of contraction of abdominal muscle? First, that is compression of abdominal content. So the diaphragm is pushed upward. Second is downward pull on the lower ribs. So decrease in the anteroposterior diameter. And third is fixation of the lower ribs. So internal intercostal muscles, they can act efficiently. Now second is the role of internal intercostal muscle. This internal intercostal muscle, their contraction effects, they are opposite to that of external intercostal muscle. This is the internal intercostal muscle. This is because of the direction of the muscle fibers, which slope downward and backward. As we have discussed, external intercostal muscle fibers, they slope forward and downward. Here, they are backward and downward. And because of that, their contraction tends to pull all the ribs downward. And because of downward pulling, there is decrease in the anteroposterior diameter as well as transverse diameter of the thoracic cavity. That these effects are opposite to pump handle and bucket handle movement. falling the pump handle effect and falling the bucket handle effect. Now, besides their role in deep breathing, the expiratory muscles are also involved in other forced expiratory efforts. They are coughing, vomiting, defecation, and Valsalva maneuver. So here we have discussed about mechanism of breathing. Next, that is pressure and volume changes during respiratory cycle. As we have discussed, that movement of air in and out of the lung depends primarily on the pressure gradient between alveoli and the atmosphere. As we have discussed, during inspiration, atmospheric pressure is more than intrapulmonary pressure, or you can say intrapulmonary pressure is less than atmospheric pressure, then only air enters. And during expiration, intrapulmonary pressure is more than atmospheric pressure. Now, intrapulmonary pressure or alveolar pressure. At the end of inspiration and at the end of expiration, here, these are the levels. At the end of inspiration and at the end of expiration, when the glottis is open and there is no movement of air, the pressure in all the parts of respiratory tree are equal, and that is equal to atmospheric pressure. You can consider it as 0 centimeter of water. During inspiration, quiet inspiration, this pressure decreases to about -1 centimeter of water, and which is sufficient to suck about 500 ml of air into the lung. And that is the period required, that is 2 seconds. And at the end of inspiration, again it comes back to 0 level. During expiration, in quiet breathing, the elastic recoil of the lungs causes the intrapulmonary pressure to swing slightly to the positive value, that is +1 centimeter of water, and which is enough to force 500 ml of inspired air out of the lungs during 2 to 3 seconds of expiration. Forceful inspiration and forceful expiration against closed glottis, that is performed forceful inspiration, that is in Muller's maneuver, and forceful expiration, that is in Valsalva maneuver. So the pressure becomes more negative in forceful inspiration and more positive in forceful expiration. Next is intrapleural pressure changes during respiratory cycle. Now, what is the intrapleural pressure? Intrapleural pressure, that is the pressure of fluid in the space between parietal and visceral pleura. Normal intrapleural pressure, when the respiratory muscles are completely relaxed and airways are open, that is about -5 centimeter of water, here you can see, and that is in the beginning of inspiration. Negative intrapleural pressure is the amount of suction required to hold the lungs. Why intrapleural pressure is negative always? Because it is the amount of suction required to hold the lungs at their equilibrium volume. Or in other words, you can say that because of this negative intrapleural pressure, functional residual capacity that is been holded. Or you can see functional residual capacity. What is functional residual capacity? That is the volume of lung at the end of normal expiration. Now, this negative intrapleural pressure, that is the result of balance of two opposite forces. Which are the two opposite forces? One, that is recoil tendency of lungs. Lungs, they have tendency to recoil, and recoil tendency of thoracic cage in opposite direction. Recoil tendency of lungs, that is because of elastic fibers present in the alveolar wall, which are under continuous stretch. And second, that is surface tension of the fluid that lines the alveoli, due to which alveoli tend to become progressively smaller and they collapse. And recoil, so these two factors, recoil tendency of lungs and surface tension. And thoracic cage recoil tendency, they are recoil tendency of thoracic cage that helps to expand the thoracic cage, and because of this opposite direction factors, thoracic cavity recoil, thoracic cage recoil tendency, that is outward, and lung recoil tendency, that is inward. Because of that, the intrapleural pressure is negative. Now, at the beginning of inspiration, here you can see at the beginning of inspiration, this intrapleural pressure, that is -5 centimeter of water. And during inspiration, due to expansion of the chest wall, the pleural pressure becomes more negative. Here you can see during inspiration, it may be as low as minus 7.5 centimeter of water, and pulls the surface of lung with great force, which creates negative intrapulmonary pressure. Because of this, inside the lung we have negative intrapulmonary pressure. Okay. During expiration, at the end of inspiration, now from 5 to minus 7.5 centimeter of water. Now during expiration, at the end of inspiration, the inspiratory muscles now they relax, and recoiling forces of the lungs, they begin to pull the chest wall back to the normal position. So now again the pressure comes back to minus 5 centimeter of water. So again you can see these are intrapleural pressure changes and these are intrapulmonary pressure changes. Intrapulmonary pressure during inspiration, it is minus 1 centimeter of water. Expiration, it is plus 1 centimeter of water. And at the end of inspiration, at the end of expiration, they become 0, equal to the atmosphere. Intrapleural pressure, beginning of inspiration, that is, it is always negative. The beginning of inspiration, that is minus 5 centimeter of water. During inspiration, it becomes minus 7.5 centimeter of water, and again at the end of during expiration it comes back to minus 5 centimeter of water. Now, factors affecting pleural pressure. First is deep inspiration. Pleural pressure may be as low as minus 30 millimeter of mercury. Second is Valsalva maneuver. When expiratory muscles are working against closed glottis, there is marked decrease in the thoracic volume, and the intrapleural pressure can be positive by 60 to 70 millimeter of mercury, greater than the atmospheric pressure. This is also seen during defecation and coughing. Gravitational forces. The pleural pressure in the standing position is more negative at the apices. That is minus at the apices, the intrapleural pressure is minus 10 centimeter of water. As compared to the bases, at the bases intrapleural pressure is minus 2.5 centimeter of water. Because of this, lungs are less expanded at the bases and more expanded at the apices. Next is injury to the chest wall. When there is injury to the chest wall, that causes exposure of the pleural cavity to the exterior, and because of that air enters in the pleural cavity. Condition is known as pneumothorax, and in this condition there is increase in the intrapleural pressure. It rises from subatmospheric level to the atmospheric level. Other is, here again you can see, other is emphysema. In this disease, lungs they lose elasticity. Either the elasticity is decreased or lost. Due to decrease in the recoiling forces of the lung, the intrapleural pressure becomes less negative, or you can say it increases. And because of this reason, in the disease, the lung alveoli expand and chest also expands and becomes barrel shaped. Now, effect of intrapleural pressure on the cardiovascular system. During inspiration, intrapleural pressure becomes more negative, and because of more negative pressure, large veins are expanded. So venous return to the heart increases. As well as because during inspiration diaphragm descends down, so rise in the intra-abdominal pressure. And rise in the intra-abdominal pressure increases pressure gradient between abdomen and thorax. So the cardiac output increases. So you can say during inspiration cardiac output increases because of two effects, because of increase in the venous return as well as descent of diaphragm, that increases the pressure gradient between abdomen and thorax and increases cardiac output. Opposite is true during expiration, mainly during Valsalva maneuver, or expiratory muscles are working violently against closed glottis during coughing, vomiting, okay, Valsalva maneuver. So here what happens, the intrapleural pressure becomes positive. And because of positive intrapleural pressure, venous return decreases and cardiac output decreases. And sometimes in in old age individual, this results in cerebral ischemia, visual blackouts, and unconsciousness. Now, measurement of intrapleural pressure. That is, first method is manometric measurement, that is made by inserting a needle into the intrapleural space, whose other end is attached to a water manometer with the help of rubber tube, and we can be able to measure the intrapleural pressure directly. Second is intraesophageal pressure measurement. Pressure can be recorded with the help of an air containing rubber balloon, and this rubber balloon is sealed over a catheter which is placed in the lower part, thoracic part of the esophagus. This intraesophageal pressure which we are measuring in the thoracic part of esophagus is equal to the intrapleural pressure because this part of the esophagus becomes a closed cavity due to closure of its lower end by cardiac sphincter and upper end by closed glottis. So these are the two methods for measurement of intrapleural pressure. Next is transpulmonary pressure. This is the pressure difference between intrapulmonary pressure and intrapleural pressure. What is the significance of transmural pressure or transpulmonary pressure? It is the pressure difference between that in the alveoli and that on the outer surface of lung. So you can see pressure, you can say it is a pressure difference between inside and outside the lungs. It is the measure of elastic forces in the lungs that tend to collapse the lung at each moment of respiratory cycle, and that is also known as recoil pressure. It is less at the bases and therefore lungs are less expanded at the bases. How, that we'll discuss. At the apices, as we have discussed, at the apices of lung, intrapleural pressure is minus 10 centimeter of water, and at the apices, at the end of inspiration and expiration, intrapulmonary pressure is 0. So the difference is 10. At the bases, intrapleural pressure, that is minus 2.5 centimeter of water, and again intrapulmonary, that is 0. So what is the difference? That is 2.5 centimeter of water. So you can say that this difference of intrapleural and intrapulmonary pressure, which is known as transpulmonary pressure, this difference is less at the bases than the apices. So the bases of the lungs, they are less expandable. So here these are the different pressure changes as well as volume changes in the lungs during respiratory cycle. Thank you all. Thanks for listening me.